So this is my lumbar spine that I did at Advent Health Daytona. So we're going to go to the AP first. So this is a 34-year-old female who had come into the emergency department with trauma from having seizures, and she was having pain in her back. There is an artifact, but it's not in the way of the permanent anatomy. And then the left marker is present. The tube was aligned and the part is positioned correctly, and the CR is the level of iliac crest, so L4, L5. Patient is positioned correctly and collimation is present. I could have came in a little more on the sides, but I did not want to get any closer to the SI joint spaces. Technique I used was 90 kVp at 15 mass, and it was an acceptable exposure. The image is of diagnostic quality, and there is no pathology seen, so it wouldn't be additive or destructive. The image is acceptable because it is not underexposed and has good contrast and brightness. Student and tech were behind the lead wall during the time of exposure, and the shield was not used because of the new protocol put into place. And then the 5 anatomy is the spinous process, the right SI joint, the ala of the sacrum, the intervertebral joint, and the transverse process. And then the lumbar vertebral bodies, vertebral joint, spinous, and transverse process, SI joints, and sacrum are all shown. The next is the LPO. So we have a 34-year-old female had come into the ED with trauma from having seizures and pain in her lower back. There is an artifact, but it's not in the way of the permanent anatomy, and the left marker is shown. There's kind of the artifact. The tube was aligned and IR is positioned correctly. The CR is L3 at the level of the lower costal margins, 2 inches above the iliac crest, and 2 inches medial to the upside ACIS. The patient was positioned correctly and collimation is present. The technique I used was 80 kVp at 15 mass and was acceptable exposure. The image is of diagnostic quality and there is no pathology seen. The image is acceptable because it's not underexposed and has good contrast and brightness. Student and tech were behind lead wall during the time of exposure, and the shield was not used because of the new protocol that has been put into place. So my 5 anatomy is I have the body of L4, the pars interarticulus, which is right there. I have the 12th rib, the 11th rib, and then the superior articular process. And then you know that this is right because the visualization of the zygophyseal joints, the LPO and RPO, will be shown on the downside. And then now we'll go into the RPO. So we have a 34-year-old female had come into the ED with trauma from having seizure and pain in her lower back. There is an artifact, but it's not in the way of the anatomy. And the right marker is present, so there's the right marker. And then I kind of counted this as an artifact. It looks like something from her gown. And then the tube, and the bucky are all aligned as well as IR. The CR is 2 inches above the iliac crest, 2 inches medial to the upside ACIS. The patient is centered correctly and collimation is evident. The technique used was 90 kVp at 15 mass and was acceptable exposure factors. The image is of diagnostic quality with good contrast and brightness. No pathology seen, so there's no additive or destructive. To improve the image, I could have moved the table over just a little bit more because we have all of this right here that we don't need. and I almost cut off right here. No pathology seen. Student and tech were behind the lead wall when exposure was taken. Patient did not have a shield because of the new protocol. The 5 anatomy is a zygoseal joint, which is right there. I have the nose of the Scotty dog. I have the pedicle of the Scotty dog, and then I have the body. And then I have the inferior articular process, which is right there. And then we know this is correct because visualization of the zygoseal joints, the LPO and the RAO will be shown on the downside. Next is the lateral. So I have a 34-year-old female had come into the ED with trauma from having seizures and pain in her lower back. There is an artifact, it's right here, and my marker is not present, and we forgot to put a annotated marker, so there is no marker. The tube, and the bucky were aligned in the IR as well. CR is to the level of the iliac crest. The patient was positioned correctly for the projection, and collimation is present. The image was acceptable, and the technique used was 100 kVp at 15 Mass. I just went up on the kVp. The image is of diagnostic quality with good contrast and brightness. No pathology was seen, so no additive or destructive was needed. I thought that the image was good. I didn't really think it needed any improvement. You can see that it's very well superimposed over each other. The student and the tech were behind the lead wall during the exposure, and the shield was not present for the patient. The anatomy is the body of L1, and then I have the intervertebral foramen, the articular process, the sacrum, and the L5-S1 joint. And you know this is correct because the intervertebral foramen, L1 to L4, vertebral bodies, the intervertebral joints, the spinous processes, and the L5-S1 junction. Next is the lateral L5-S1 projection. So we have a 34-year-old female had come into the ED with trauma from having a seizure and pain in her lower back. An artifact is there, but it's not an anatomy, and my left marker is seen. So there's my marker, and then the artifact's kind of up here. The part 2 bucky and IR were all aligned, and the CR is perpendicular to the IR with an angle of 5 degrees, and then 1.5 inches inferior to iliac crest and 2 inches posterior to ACIS. Patient was positioned correctly, and collimation is evident. Technique used was 95 kVp at 15 Mass. Image is of diagnostic quality with good brightness and contrast, and no pathology is seen, so we wouldn't need the additive or destructive. I could improve this image by bringing it up just a little bit more to get all of L5 because I only got a little bit of it. And then student and tech were behind the lead wall during exposure, and patient was not shielded. My 5 anatomy is I did L5, and then I have the lumbar sacral joint, the promontory of the sacrum, I have the coccyx and the greater statistic notches. And then you know this is correct because L5-S1 joint spaces is open, and the sacral iliac joints. And that is my presentation for the lumbar spine.